Welcome to Eye Contact. I'm Aidan Hanratty. Today we are talking to Marc Labetoulle about implementing ocular surface disease treatment strategies to improve surgical outcomes. Welcome, Dr. Labetoulle.
Welcome, Aidan.
Thank you. What are the essential pieces of information you need to diagnose dry eye?
Well, this is a very important question. There is one main difficulty considering dry eye patients. There is much discrepancy between sign and symptom in at least 50% of cases. So we have to focus on both aspects of the disease, the subjective symptoms and the objective signs. Concerning the symptoms, the due to report has proposed some triage questions, just very short question to make sure that the patient is suspect of dry eye disease and has no other obvious ocular disease such allergy or something like that. And we also have to implement the previous history, the previous medical history about rheumatoid diseases, about lupus, Sjogren disease, etc. On the other side, we have to look at the objective signs. So these objective signs can be assessed primarily by the quality of the breakup time and the level of the ocular surface damage thanks to the fluorescein staining.
Discuss the importance of things like that, tear breakup time, fluorescent staining, slit lamp exam.
Well, tear breakup time is the most constant time in every types of dry eye disease. As you know, there are two main types of dry eye disease. The first is aqueous deficient, the second is hyperevaporation. But indeed, in most of cases, there is a mix of the both. In both cases, the breakup time is decreased. So this is a non-specific but very constant sign of dry eye disease. The level of corneal damage is also important to assess because it will not only give you an idea about the presence of the dry eye disease, but also it will inform you about probably the reason or the main reason of the dry eye disease. For example, if the corneal damage is maximum in the interpalpebral area together with a conjunctival damage, this is probably due to a deficiency in aqueous production. But inversely, if the damage is mostly inferior, you will have to check for any eyelid dysfunction as the first cause of the dry eye disease.
What is the value of symptom questionnaires for patients whose primary reason for the visit is for cataract surgery?
Well, I think questionnaires are very practical in everyday clinical practice. Of course, we can't ask to all patients candidates for cataract surgery to fill in the questionnaire because it will be time consuming. But in selected case, I mean all the patients who are at risk for the dry eye disease, we can ask them to look at the questionnaire and to give their answers. There are two questionnaires that are proposed by the due to reports. The first is the OSD and the second one is the DQ5. I have more experience about the OSD. This is very practical. You give the questionnaire before the patient enters your office. So the patient will use his waiting time to fill in the questionnaire, and you will see very fast if the patient has a bad quality of life due to dry eye disease, and even if there is any symptoms about dry eye disease or any ocular surface disease.
Why should cataract surgeons consider point-of-care diagnostic tests?
To my perception of the disease, I think that every cataract surgeon should consider this examination for all patients candidates for cataract surgery, but not at the same level. If the patient has an already known history of dry eye disease or any other disease that lead probably to dry eye disease, like for example rheumatoid arthritis, then a complete checkup is necessary to make sure that the dry disease is not there, or if the dry disease is already known, to have a good idea about the severity of the disease. For the other patients who are only at risk, I mean patients with previous allergy, previous glaucoma, previous refractive surgery, etc., a checkup less complete but with the minimal aspects, as I said before, breakup time, corneal damage, questionnaire, etc., is necessary to evaluate the level of the dry disease if there is one.
Okay. Beyond artificial tears, what are the key treatments or therapies for cataract patient or cataract surgeons to give to their OSD patients?
It depends indeed of the type of the dry disease. As I said previously, there are 3 types of dry disease: aqueous deficient, hyper-evaporative, and a mix of both. So if there is an MGD, the artificial tears will not be sufficient, and you need at least to educate the patient about lid hygiene. In some cases, you may need more, for example, systemic or topical antibiotics or fatty acid intake. It is debated, but there is still some clues about it in the literature. And if necessary again, you can go to further alternatives like thermal expression of the eyelids, probing of the mammalian glands, etc. When you have a high level of inflammation on the ocular surface, artificial tear will not be enough as well. And in these cases, it is recommended, to my point of view, to postpone the surgery and to treat the patient with more efficient treatments, including the immunomodulatory drugs such as cyclosporine and levetiracetam.
What advice would you have for cataract surgeons who are facing a dry eye patient just before, during, and after surgery?
Well, I think that the first thing is not to perform surgery until the ocular surface is not good enough. Once we are at this level, we should avoid the NSAIDs before the surgery because we know the risk of corneal melting is in such patients. At the time of surgery, the idea is to reduce all the injuries to the cornea during the surgery. So it includes reducing the number of eye drops before the surgery, reducing the light exposure, avoiding an aspirating speculum, limiting the thermal energy delivered by the machine, etc. And in the post-op period, it is also important to avoid, again, the NSAIDs because of the corneal melting, together with treating the inflammation of the ocular surface, which will be increased by the surgical session. In that purpose, some eye drops containing steroids without preservatives could be very helpful, and together with antibiotics, of course, but I think it's better to avoid the most epitheliotoxic of them. Thanks.
Thank you very much for joining us, Dr. Labetoulle.
Pleasure.
For more information on this and related topics, please visit us at eurotimes.org.